All right, this is the last recording for chapter 22. So, talking about the potentially violent patient. Those that become very violent, physically violent, is just a very small percentage of the patients that undergo a behavioral or psychiatric crisis. But we just need to be aware that the potential is there. Truthfully, any of our patients, whether they're experiencing a traumatic event or a medical event, have the potential to be violent. But I mean, when you have some sort of emotional crisis tied to it, definitely that ups the ante. So be alert for signs of potential violence. And you can assess it based on a couple of different risk factors. So, does the patient have a history of hostile, aggressive, violent behavior from previous calls? Posture. Is the patient tense, rigid, kind of sitting on the edge of his or her seat? If they're standing, are they pacing back and forth? Obviously, agitated. The scene, if they have a weapon, we're not going to go anywhere near them, or if they have the um, potential to get to a weapon very quickly. One of the worst places to um, have a patient that is agitated is either in a garage where there's tools nearby, or in a kitchen where basically the majority of the kitchen can be used as a weapon. So try and get them to a different place in the house if you can, where they have less access to all of those things. Vocal activity. Is the patient loud? Are they using obscene words? Um, Oftentimes, just their speech patterns are going to indicate where they're at emotionally. Physical activity. This is the most telling factor of all. If a patient is pacing, can't sit still, fiercely protecting their personal space, they won't let you get near them, they don't want you to touch them. If they have tense muscle, clenched fist, glaring eyes, um, generally a patient that's been extremely boisterous and talking, and more obviously agitated. If they suddenly become quiet and start staring unblinkingly at a portion of your body, that's typically where they're going to strike and they're getting ready for it. Other factors to consider if your patient is going to become violent or not. So, poor impulse control, if they have a history of an uncontrollable temper, anytime you throw some substance abuse on it, people typically don't act with the best control. Depression does account for about 20% of the attacks because they feel like they have nothing to lose. And then functional disorder, if the patient is telling you that the voices are wanting them to commit some sort of violent act, believe them. Oftentimes, that feeling of needing to listen to the voices becomes overwhelming. For suicide, depression is the biggest factor that contributes to suicide. Oftentimes, there's a misconception that people who threaten suicide will never actually attempt it, which is not true. Suicide is often a cry for help. If somebody says that they want to commit suicide, that's kind of their last ditch effort to get somebody to stop them before they actually do it. Most people that feel suicidal or want to commit suicide actually don't want to die, but they are at a point where their feelings, their depression, their everything that's going on has become so overwhelming that they truly see no way out. And it's not selfish in the sense that a lot of people think that way. It's people that commit suicide tend to think that those that they love will be better off without them, that they and their problems and their mental health have become such a burden on those around them and those people that they love that they believe that when they're not there, their family, their friends, their workplace will truly be better off without them. So it's actually, a lot of people will say, well, that's just a selfish way out. And it's really not. It takes a lot of thought to actually go through with a suicide plan. So, warning signs. Are they tearful, sad, deep despair, feelings of hopelessness, feel like they're drowning in their own life? Do they avoid eye contact? Do they speak slowly? Are they kind of vacant? Basically, kind of talking as if they're not really there? Do they have the ability to talk about the future and things that they see for themselves in their life? Um, is there any suggestion of suicide, or do they just flat out have a plan? Um, Here's a couple more risk factors that can kind of predict people that are at risk for suicide. The big one is alcohol or substance abuse, especially those that are increasing use, because they have a lack of rationalization, and then they add that on top of the feelings of hopelessness, and it just helps reduce inhibition. Additional risks, are there any unsafe objects nearby, or is the environment itself unsafe? Is there evidence of self-destructive behavior? Is there imminent threat to the patient or to others? Does the patient have any other underlying medical problems? Are there any cultural, religious, or social beliefs that promote suicide? It's becoming very normalized in our society right now. And so it doesn't carry the stigma that it used to. And then, has there been trauma to the patient? One thing that you need to kind of have in the back of your mind is that not always, but the suicidal patient may be homicidal, and more times it's that they can't carry out the suicide by themselves. And so if they can do what's called death by police, then they may end up taking somebody down with them just so that the police will carry through and end their life for them. Post-traumatic stress disorder and returning combat veterans. And truthfully, you don't have to be a soldier to experience post-traumatic stress disorder. It comes after any sort of experience or injury that you're exposed to that causes significant emotional trauma. So this could be somebody that was sexually or physically assaulted, those that are victims of child abuse, serious accidents, natural disasters. War is definitely on that. Loss of a loved one or extremely stressful life changes. And PTSD doesn't necessarily have to be tied back to a singular event. It's estimated that 7 to 8% of the general population will experience PTSD symptoms sometime in their life. Military personnel who have been in combat do have a high incidence, but us as pre-hospital care providers also have very, very high instances, and help is very stigmatized still. And so we often don't follow through. Military personnel tend to see like news stories and whatnot that continue to trigger them. With us, it's oftentimes we'll be watching a show and we'll identify something that's happening in the show with a previous call that we were on. Symptoms of PTSD: helplessness, anxiety, anger is a big one. Fear, kind of feeling like you're back in that setting that's frustrating. People with PTSD oftentimes try to avoid those triggers or those things that bring them back to the time of the incidences that led them to have this. They avoid like loud noises, smells, interactions with people that are associated, and they suffer constant nervous system arousal that really just can't be suppressed appropriately. So their heart rate is increased, pupils are dilated, systolic blood pressure increases, senses are sharpened, mental acuity is heightened. They tend to display hypervigilant behavior or an exaggerated startle response to what they perceive as danger, which we might not think of anything as being terrible. They can often relive the traumatic event through thoughts, nightmares, flashbacks. And so it's just something that continues to happen over and over and over and over. Dissociative PTSD occurs when a person attempts to find an escape from that constant internal distress. And then it can manifest in other psychological conditions such as personality disorders, increased functional impairment, but it doesn't always go that way. Many veterans develop a host of adverse physical conditions in addition to their PTSD, some from injuries that they have, some from unfocused pain that's not associated with any specific body part. Combat veterans tend to be very prone to like early heart disease, higher incidence of type 2 diabetes, and then a loss of gray matter in the brain. And then another consideration is that the combat veteran definitely has a higher incidence of traumatic brain injury sustained from trauma secondary to an explosion or some sort of injury. And symptoms may honestly go undiagnosed for several different reasons because they're so similar to PTSD. The patient may downplay the syndrome. So the best thing we can do when we're talking to somebody is to eliminate like excess noise. Try not to touch them without explaining first. Kind of move slow. Caring for combat veterans definitely require different type of understanding and compassion, as well as specialized attention. Be careful how you phrase your questions. Use a calm, firm voice, but be in charge. Respect their personal space. Try and limit the number of people involved, and make sure that you ask about suicidal ideations. Asking about it is the best thing you can do, not avoiding it. Ensure that there's nothing the patient can access and use as a weapon. Physical restraint may not be effective with combat veterans. It just escalates and makes things so much worse. So try and calm the patient. If you need to, chemical restraints are probably going to be your best bet. So medical considerations. There's a lot of medical and legal aspects to emergency care that become more complicated when a patient is undergoing a behavioral crisis or a psychologic emergency. Legal problems are reduced when the patient actually consents to care, but a lot of times you have to gain their confidence and trust before they'll allow that to happen. Once you've determined that a patient has an impaired mental capacity, you have to decide whether they need immediate or they can wait on medical care. They may resist your attempt to provide care, but we're not going to leave them alone. We're definitely going to request law enforcement to help out. Consent, one thing that comes into play here is implied consent is assumed with a patient who is not mentally competent to grant consent, and you certainly have to document that thoroughly. And those clear-cut matters are not always there when you have somebody that's having a psychiatric emergency. That's why having law enforcement there can be helpful. Limited legal authority. We as EMTs have limited legal authority to force a patient to undergo medical care when there's no life threat. So we need to be familiar with local and state laws regarding that type of situation. Remember that a competent adult has the right to say they don't want treatment, right to refuse treatment. So a court of law will only err on the side of us if it's deemed that it's medically necessity and that the patient was in true Um,